esophageal fistula, or they can also have like esophageal atresia. When we say esophageal atresia, like we know that we have our trachea and we have our esophagus. If they go like a side by side, then this attaches to your stomach. Okay? When we say esophageal atresia, it does not attach to the stomach. So that's atresia. Okay, it does not attach, so it's just like a pouch. Instead of doing that, it attaches with the trachea. So you call it as a tracheoesophageal fistula with esophageal atresia. That's what TEF and EA is. Okay? It can happen separately or it can happen in a combination too. And usually it's very rare. You can see that 1 in 4,000. More in males, low birth weight, preterm, or mother has a history of polyhydramnios, like too much amniotic fluid. So these are the different types. Just kind of understand, you will be, it doesn't matter which one they come with, the care is almost same. Okay? So, but it can be, look at that, this is a normal anatomy, like I said that, your trachea and it goes, this is normal. This should be occurring normally to have a proper gas exchange. Okay? The gas supposed to be going up here, going to the bronchus, then going to the lungs in the bronchioles. Not coming from here, going to the stomach, not coming from here, going to the esophagus. You see that how many ways it can go up. Or you don't want any esophageal stuff going into trachea. So common one is atresia with fistula. This is the most common one. Okay? They will have esophageal atresia where it does not connect. But there is a distal fistula, not proximal. It's a distal at the end of the stomach. Okay? So that's 80 to 90% of cases are those where you see that. 3 C's. Don't forget. When the child is born, when are you going to find these? When is your first suspicion arises? The person can have a TBS. The first feeding. Sometimes it depends upon the severity or what type of fistula you might see immediately after breastfeeding, baby turns blue. Okay? So coughing, choking, cyanosis, excessive salivation, drooling, apnea, respiratory. These are the ones that you can see it if it's not that severe. Okay, but if it is, then these are the, I have seen the baby just turning blue. Immediate medical attention. If the nurse sees there is a frothy saliva, difficulty with swallowing secretions, or unexplained episode of apnea, cyanosis, O2 stats are dropping, and you suspect it's a TEF, call the doctor. So diagnosis usually first it's made on the assessment, nursing assessment, or the signs and symptoms, you know. So once you start expecting it, then you call the doctor, so then they do some radiographic studies, then the bronchoscopic examination. So the other thing is, what does failure to pass 10 French tube tell you, nasogastric tube? They check it for atresia. You know, if you put the tube, so that's checking for esophageal atresia. Collaborative prevention of pneumonia, keeping airway patent, gastric and blind pouch decompression, surgical repair. So you see that they have to repair their surgical. If this is a tube, which one you think they will be doing the first? Closing this one first. You know? So the kid might be on a gastrotomy feeding, they might be on a TPN. Okay, so sometimes it's in the different stages. So when I was working in a pediatric, I had only one case I have seen with the TBS. He was born at 32 weeks. It's a male, typical, same risk factors. So he was born with a TEF and atresia both. Yeah. So the first thing, they closed the fistula. So he came on the floor back. He was on the nasogastric tube feeding. So they put not the gastrotomy feeding. Okay. So the second, they have to wait until kids start gaining weight. You don't want to do 2 surgery at a time. And they get a little bit more mature, so they did the second surgery. And that kid, we resuscitated him 3 times. And he was the one that I learned how to intubate a baby. Because in India, we do have the, like an on-call physician, they have their office, they stay there. So, but, you develop that sense with it. He was with us for 2 or 3 months. So we just said, I can't wait, he's coming, the baby's turning blue, we need to do something. We said, how hard it can be. At that time I was thinking, I said, how hard it can be, just putting NG tube in there. So we did the endoscope, the charge nurse was there, so we intubated the baby and we started the pulmonary by the time doctor. So he saved, 3 times we did that on him. So on 3 different occasions. So when he was 4-year-old, he came to visit us. The mom was so happy. It was a typical, she didn't have any kids. That was the only boy was born preterm after 14 years. So it was like a joy. I can never forget that case. So we have that little bitty one. He has, they did it through here, 1 incision here. On the other side, he had a chest tube, okay? So I'm telling you because you will see that all their stuff next one later. So thoracotomy, see, with the division and ligation of the TF, so they go from here. So they will have gastrotomy. So if they're 2, and the care, their preoperative care is same for every patient. It doesn't matter. Okay, you're going to tell them they understand it. They understand person will come out. They might be unconscious. They might be on pain medication. They'll have incision. You're going to tell them they might have brain. They might have a chest tube. Okay, so those are the things you want to tell. Post-operative. Here you're going to focus more on the thoracic, okay? The neck and the thoracic. So this is the one you do in the preoperative. Preoperative, our main goal is you're not going to feed it, keep them NPO. The other thing is they have problem with swallowing too, so the secretion and saliva is still there. That saliva can go into your trachea too, so that's why suctioning is very important to keep that secretion. Broad-term spectrum antibiotic therapy, if you see in the CBC, WBC, the child is having a fever, and those are the things that you want to do for sign and symptoms of infection. So more preoperative care. So while you're waiting for the surgeon to make the plan, so these are some of the nursing interventions that we're supposed to be doing it. Okay, if you have a patient who is admitted with TPF, but they're waiting for the surgery, placing supine with head of bed at least 30 degrees. Okay, so because you don't want them to aspirate. Immediately, airway clearance is your number 1 goal. Clear the airway. Okay. The blind pouch is kept empty by intermittent or continuous suction. So you think that it's why we want to put the suction here. Because saliva and others is still coming in there, so you want to get everything out, otherwise it will start going in here. Okay, so that's why it's important. Percutaneous gastrotomy is usually done, so if they need any feeding, but you don't feed them free of surgery to keep it, that's why it's left open. And feeding through the G-tube and irrigations are contraindicated before surgery. Then the post-operative is the same one. So you see that here we are focusing more on thoracotomy, chest tube care, pain management, suction. Even they have the surgery done, you don't want to feed them immediately. They might be on the TPN, and TPN is total parenteral nutrition is always given through a central line. Never ever given through peripheral lines. Okay, tell me some of the nursing care you are going to do for a patient who has a thoracotomy and chest tube. Thoracotomy is just like a thoracic incision, and they went through the thorax and there's a chest tube in there. It's an opening in the thorax.
Would it be the same care as a chest tube?
Yep, same care as a chest tube. So what do you do in chest tube?
You make sure that ball, first pressure is in place, it stays in place, but you make sure that ball is leveled.
You follow the levels with the floating, is it a ball thing, something in there? Yes. So you follow that means it's moving. Okay, so that is functioning. So the other thing, always leave at the level, never ever lift up above the level of the insertion. Okay, the other thing is, are you supposed to milk or no?
No.
No milking, yes. That's how we used to do a lot. Okay, it's a new evidence base now. No milking of the chest tube, and want to make sure you get that. Rest of the stuff, you want to make sure it stays clean, no sign and symptoms of infection. And watch for what is coming in there, the color, amount, and excretion. How do you make the amount? We mark it. Remember, every shift the nurse comes in there when you take them, so you mark it, and that goes into your intake and outputs. So here we are going to wait until you're waiting to start G2 feedings. The person will be on a TPN, okay? Before oral feedings are initiated, make sure the chest tube is removed. So main criteria is, like I said, they don't, there's a 3 criteria for the, if it's a preterm. They start gaining weight, okay, and their intake output is normal, and they also start feeding, tolerating feeds well. Okay, so those are the criteria when they discharge them. So these are the complications that you will be watching if you have a patient with TEF, okay? Upper respiratory infection, because there is a connection between your GI and the respiratory. Pneumonia, respiratory distress. These are the ones that can happen after surgery, anastomosis, okay? So what is anastomosis? They go there and they join it. So there can be a leak in here when they join it, okay? So that you have to watch it. So in those cases, you will see a permanent chest drainage, increased WBCs, temperature instability. What is trichomalacia? Flappy, like the muscles are loose in trachea, that's a trichomalacia. It's like they lost their tone, so you call it a trichomalacia. So when they breathe like a flappy, like, so that's a trichomalacia. Okay. They can have a reactive airway disease, problem with thriving and weight gain. So this is very important. Anytime there is a respiratory difficulty, even after you did the suction, so you need to call the surgeon for that. That's post-operatively. So tracheal wheezing, expiratory, it's like a harsh, barky cough. Okay. Failure to thrive, increased respiratory distress, difficulty clearing, reflex apnea, like a dying spells. Okay? So they can have those. That's a trichomalacia. So here you see it. This is normal. Okay. So this is your like trachea. They are inside the trachea, those rings. So in inspiration they stay like this. In the expiration they goes like this. Okay. Here you see that they have lost their, I call it a flappy. You know, I compare it with my arm like this. So this is trichomalacia. So inspiration, you like, there is no tone in there, then this is expiration. So discharge teaching, usually you need to understand at what point they're going. I think sometimes the incision is completely sealed, okay? So you need to tell, most your teaching will focus on their feeding and the respiratory stuff. They need to watch them, their feeding techniques, okay, suctioning, respiratory distress, so any resources they need when they go home, and home health services. It's really interesting, like anybody who works with the children or in, nobody